Okay, welcome guys. Welcome to the class once again. So we'll start the class. We'll start as cool as this, right? So previously we stopped. I think this is sorry. I think this is the 11th part. We'll just correct it here. I'll just take the eraser. Wait, just 1 minute. Just 1 minute. I'll just clear it off. Why? Because I want to just keep it as clean as it is, right? Because I want my students to understand everything as crystal clear. So this is the 11th part. Okay, everyone, so get ready. We'll get into the class finally. See, I will speak one thing for sure. I just want to say it as frank as I am. I'm chewing bubble gum. Don't think otherwise. Don't think like any negatively, because I just want to keep myself fresh. Okay, I'm always fresh. Don't think like that. But still, today I just want to take some bubble gum, so that I just want to stay in the class as level as I am, as fresh as I am, right? So previously we stopped here. Okay, the side effects of calcium channel blockers. The side effects of the calcium channel blockers. So I think we just stop here. AB block. So one of the key side effect of the calcium channel blocker is AV block, arteriovenous block. But in which calcium channel blocker? It's seen only in verapamil and diltiazem. Remember this, it's very important MCQ. And one more thing is, verapamil and diltiazem should not be given with beta blockers. Verapamil and diltiazem should not be given with beta blockers. Please keep this statement in mind, or otherwise you write somewhere verapamil and diltiazem should not be given with beta blockers, right? And now we will discuss something about hypolipidemic drugs. We will discuss something about hypolipidemic drugs. Don't think otherwise. I will just make it something fast so that you can go on with the flow, right? Hypolipidemic drugs. So what are the hypolipidemic drugs? So actually, hypolipidemic drugs are clearly classified into something which decreases LDL. LDL means low density lipoproteins. Something which decreases triglycerides, and something which increases high density lipoproteins. Can you tell me which are good ones? High density lipoproteins are good ones. LDL is bad for health, and triglycerides are also bad for health. So we are actually classifying these hypolipidemic drugs into 3 categories according to the mechanism of action. One class of drugs, some class of drugs decrease the lower density lipoproteins, LDL. Some class of drugs decrease the triglycerides. Some class of drugs increase the high density lipoproteins, low density lipoproteins, high density. So some class of drugs increase the high density lipoproteins. So listen this class very much keen and absorb, because you will get not less than 2 MCQs from this class, right? So first one is, the first class of drugs which decrease the LDL is statins. The second one is bempedoic acid, and third one is ezetimibe, right? Ezetimibe. Fourth one is inclisiran. Remember, inclisiran. Fifth one is PCSK9 inhibitor. This PCSK9 inhibitor, it is very important. It's an INICET question. Remember this, PCSK9 inhibitor. And what are the class of drugs that decrease triglycerides? Fibrates. I think you know this fibrates. Clofibrate, genofibrate. These all are fibrates. Then icosapent. Then omega-3 fatty acids. Can you tell me in which food omega-3 fatty acids are rich? It is in fish, cod liver oil. Omega-3 fatty acids, it's in the fish, cod liver oil, and it decreases the triglycerides, right? Always include omega-3 fatty acids in your food. And which is the component that increase the HDL, high density lipoproteins? That is niacin. Very important, right? But trust me, the side effects of niacin is a potential MCQ. Remember, it will be coming in Neet PG. Okay, the side effects of niacin is very important. Now if you ask me, sir, we just explain this one, but I think you will miss something here. Yes, I missed something in this. You have 2 more classes, 2 more types of drugs which decrease the LDL. What are those ones? That are bile acid sequestrants. I know why you are just surprised. sequestrants. I thought most of the students may think like sir has forgotten these two class of drugs. No, I'm just very much alert, right? And one more thing is lometapide. This bile acid sequestrants, you see this bile acid sequestrants is also a Neet PGMCQ. Always remember the mechanism in hypolipidemic drugs. The mechanism is very important. The mechanism of action is always an MCQ. Please remember this. You should be very much thorough with the mechanism of action of hypolipidemic drugs. Now coming to the real deal, right? So I will write the hypolipidemic drug here, as well as the mechanism of action, as well as the uses and the side effects. Please listen this table. Just write this table. It is very important. You will get one MCQ from this table for sure. Now what is the first hypolipidemic drugs? Those are statins. Can you tell me some examples? Atorvastatin, then rivastatin, pitavastatin, rosuvastatin. These are obviously statins. What is the most potent statin? This is an MCQ. What is the most potent statin? It is pitavastatin. Pitavastatin more than rosuvastatin. Not rosuvastatin, guys. Rosuvastatin is not the most potent. It's pitavastatin. Pitavastatin is the most potent statin. Pitavastatin. Now, if you ask me, which one decreases the maximum LDL levels? It is the rosuvastatin. Now this is an MCQ. Decreases maximum LDL levels in all the statins, right? When compared to all the statins, rosuvastatin is the drug which decreases the maximum LDL levels. This is an MCQ. Remember, okay? Now, what is the longest acting statin? What is the longest acting statin? What is the longest acting statin? It is rosuvastatin. Rosuvastatin more than atorvastatin. Rosuvastatin more than atorvastatin. Now remember on this, all statins are metabolized by cytochrome P450 except, this is an MCQ, except it is pravastatin. It's pravastatin, right? It is not metabolized by cytochrome P450. It is an MCQ, pravastatin. Now coming to the mechanism of action, how these statins achieve the hypolipidemicity? How these statins achieve the how they decrease the low density lipoproteins, right? They inhibit HMG CoA reductase, thereby decreasing the LDL. This is very important mechanism. You just remember this. Statins work by decreasing the inhibiting. They inhibit the HMG CoA reductase enzyme, thereby decreasing the LDL, VLDL as well as triglycerides also. Okay, and they sometimes they also increase high density lipoproteins. Okay. Now, what are the pleiotropic effects of these drugs? What are the pleiotropic effects of these drugs? Pleiotropic effects of this drug. I know you very well much know what is meant by pleiotropic. Okay, no need to explain. What are the pleiotropic effects of this drug? They are also anti-aggregants. What someone is asked, see, pleiotropic effects means these are the effects. These are the beneficial effects which they provide beside performing their actual benefit, actual functionality. Besides providing their actual functionality, they will also give this beneficial effects also. They will also provide this beneficial effects also, means sidewise benefit, sidewise functionality, right? That is parallel functionality, which are minimum actions but still they are benefit, right? They are utilized as anti-aggregants. They act as anticoagulant. They also act as anticoagulant. They are also anti-inflammatory. They can also be determined as antioxidants. They also act as antioxidants. they increase the nitric oxide. Nitric oxide is a potent vasodilator, remember, and they are also good plaque stabilizers. It is an MCQ. They just stabilize the cholesterol plaques, atheromas also. Now, statins are drug of choice in type 2 hypercholesterolemia. Type 2 hypercholesterolemia. They are also drug of choice in familial hypercholesterolemia. And they are primary or secondary prophylaxis. They are the primary and secondary prophylactic drugs of MI and stroke. And they are generally given as nighttime dosing. But this nighttime dosing is not mandatory for rosuvastatin and atorvastatin. This is a potential MCQ. Nighttime dosing is not mandatory for rosuvastatin and atorvastatin. Now if someone using protease inhibitors, sometimes protease inhibitors also cause hyperlipidemia or dyslipidemia. Protease inhibitors, obviously their side effect is dyslipidemia. Now what is the drug of choice for protease inhibitor induced dyslipidemia? That is pravastatin. It is the drug of choice. I will just mark with red. Don't think like it is mixed with this upper statement. No, pravastatin is separate statement. Pravastatin is the drug of choice for protease inhibitor induced dyslipidemia. Remember this, very important. Why? Because you may get an MCQ like a 23-year-old using a drug of protease inhibitors, a drug which is related to protease inhibitors, and finally they land up with dyslipidemia. What is the drug of choice? Is pravastatin. Remember, what are the side effects of statins? First one is myopathy. What is the side effect of statins? Is myopathy. Then they are also hepatotoxic. They are insulin resistant also. This is important. They are insulin resistant. So always use in cautious while prescribing it for diabetic patients. They cause insulin resistance, and they are contraindicated in pregnancy, and they are also contraindicated in children less than 10 years. So these all things, please all of you just remember, just read this and remember. Now coming to one more thing, pravastatin. I will say pravastatin. What is pravastatin's use? Pravastatin is the drug of choice for protease inhibitor induced dyslipidemia. Remember, this statement is very important. And pravastatin, it is contraindicated in children less than 8 years. This is an important statement. While giving a clinical MCQ, always check the age groups. Why? Because you have some serious contraindications in statins. Okay. Now coming to the next one, it is bempedoic acid. What is the next drug which decreases LDL? It is bempedoic acid. Bempedoic, how does it act? It inhibits ATP citrate. It inhibits ATP citrate lyase. Okay. And it decreases LDL. Okay. What is it used? What are its uses? It is a add-on for statins. Now what are the other drugs which decrease LDL? These are bile acid sequestrants. Or wait, I'll just call it bile acid binding resins. We will discuss this. Bile acid binding resins. Okay. What are those bile acid binding resins? First one is cholestyramine. Next one is cholestyramine. Next one is cholesterol. Okay. What they do is, what is their mechanism of action? They inhibit enterohepatic circulation of bile acid. They inhibit enterohepatic circulation of bile acid, thereby leading to decrease in LDL. Okay. Now these uses same like bempedoic acid. It is an add-on to statins. And one more thing is, I will just write it with red color. Remember this. They are the preferred drugs in pregnancy and children. But if you ask me the side effects of bile acid binding resins, the side effects are hypertriglyceridemia. This is the side effects of bile acid binding resins, hypertriglyceridemia. And another one is hyperchloremic alkalosis. This is one more serious side effect, hyperchloremic alkalosis. And they sometimes cause GI upset, decreased absorption of other drugs. And this decreased absorption of other drugs, this side effect is seen minimum in cholesterol. Means cholesterol is something safer than rest of the true drugs, that is cholestyramine and cholesterol. But the most important side effects is hypertriglyceridemia and hyperchloremic alkalosis. This is about bile acid binding resins. Now we will discuss something about the next forward on treatment. What is it? What is the next forward on treatment? PCSK9 inhibitors. We discussed about this. The PCSK9 inhibitor, I previously said I will discuss in the next topic. Now we will discuss what are the PCSK9 inhibitors. What are the PCSK9 inhibitors? Evolocumab. Just 1 minute. I'll just write it down. Evolocumab. Right? Evolocumab. Just one more drug is alirocumab. So what is their mechanism of action? They prevent, remember this, MOA is very much, they prevent degradation of LDL receptors. And one more important point is, these PCSK9 inhibitors, that is evolocumab and alirocumab, they give or they exhibit maximum decrease in LDL. These drugs, they do the maximum decrease in LDL component. And what are their uses? They are add-on for statins. All these drugs are add-ons only. You take bempedoic acid, it's an add-on. PCSK9 inhibitors, it's an add-on. Then bile acid binding resins, they are add-on. Mostly these all are add-ons. Why? Because the main drug of choice are always statins. You take familial hypercholesterolemia, they are the drug of choice. You take one more, that is primary hypercholesterolemia, they are the drug of choice. So obviously statins are mostly the drug of choice. Always remember this. Okay. Now coming to the next drug that is, can anyone tell next drug? Inclisiran. How does the inclisiran act? And I think inclisiran might come as a MCQ this year. Inclisiran acts. What happens is, you have a siRNA, right? You have siRNA breaks mRNA of PCSK9, thereby leading to decrease in LDL. Now one more thing is, they block the angiopoietin. They block the angiopoietin like protein 3. They block the angiopoietin like protein 3, thereby blocking the LDL receptor, thereby leading to decrease in LDL and triglycerides. Right? What happens is they initiate the siRNA, leading to breaking of mRNA of PCSK9. Then this leads to decrease in LDL, proteins to lipoproteins. And one more mechanism of action is, what they do is they inhibit which drug they do this? Evinacumab. This evinacumab inhibit the angiopoietic like protein 3, thereby leading to blockage of LDL receptors, leading to decrease in LDL and triglycerides. Now, what is the use of inclisiran? It is an add-on to statin, as simple as like. What is the use of evinacumab? It is used in familial hypercholesterolemia. Very, very important. Familial hypercholesterolemia. It's very, 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 very important. Always remember. Right? And it can also be used as add-on to statins. Okay? Now the final drugs are fibrates. Okay? What are the examples? First main example is clofibrate, fenofibrate, benzafibrate, gemfibrozil. Remember this drug, gemfibrozil. This is very important. How do all these fibrates act? It is simple. They just stimulate the PPAR alpha and increase LDL lipase enzyme synthesis. So what happens? Decrease of triglycerides, chylomicrons and VLDL. Okay. Now, what are the fibrates uses? Now, fibrates are very important. Fibrates are used as drug of choice in hypertriglyceridemia, and they are also drug of choice in chylomicronemia. Okay, syndrome. Chylomicronemia syndrome. But the fibrates' main important point is their side effects. That is cholelithiasis, stones in the gallbladder. They cause a serious side effect, that is cholelithiasis, stones in the side effect as well. Stones as a side effect, stones in the gallbladder as well. One more side effect is myopathy, cholelithiasis and myopathy. Now, can you tell me any other drug which causes cholelithiasis? Progesterone in pregnancy. Always remember, progesterone in pregnancy, if given for more than 14 weeks, then it leads to cholelithiasis, gallstones. Remember, it's one important step. Okay. Now coming to the next topic. What is the next topic we should be discussing? What is the next topic? Can anyone guess? What is the next topic? I think we got some drugs still. I remember some drugs. Wait. We have one more drug, icosapent. How does the icosapent works? It decreases the triglycerides. Rich VLDL synthesis, which are secretion by liver. right? What they do is they decrease the triglycerides rich VLDL synthesis or secretion by liver. They decrease the both the actions. And also one more important thing of icosapent is it inhibit platelet aggregation. Very important, right? And what are its uses? It is simple hypertriglyceridemia, and it is also a add-on for statins. Why? What its benefit is? It decreases CVS mortality. It's the benefit of icosapent. Now, one last drug. This is the drug which increases HDL, high density lipoproteins. What is the mechanism of action of niacin? It decreases hormone sensitive lipase enzyme synthesis. It is the mechanism of niacin. Now, what are its uses? Dyslipidemia with HDL decrease. The condition where there is a problem of dyslipidemia as well as there is a decrease in HDL, you can prescribe niacin as the drug. But what is the potent side effects of niacin? That is very important. The side effects of niacin are very dangerous. First one is hepatotoxicity. That's one serious thing. Then insulin resistance. Next, one more side effect is flushing. A female of age 48 years having a problem or condition of dyslipidemia associated with decreased HDL was prescribed a drug. After a period of time, the patient complains of flushing, or the doctor or the clinician has observed flushing in the patient. Then obviously what is the drug? It is niacin. Remember, niacin causes flushing, hepatotoxicity and insulin resistance. These are all things you please read once again. Okay. Now with this we finish the drugs and mechanism. We will just take how we approach a patient with increased cholesterol levels or hypercholesterolemia or hypertriglyceridemia or any other thing, right? For example, there are high LDL levels with or without ASCVD. ASCVD means atherosclerosis cardiovascular disease. What are those diseases? ASCVD, MI, angina, stroke. So you got a patient with a high levels of LDL, low density lipoproteins, with or without atherosclerotic cardiovascular disease, that is MI, angina or stroke. So what is your follow-up? What is your process of approaching the patient? So we will just decide whether the patient is without ASCVD or with ASCVD. Now, if the patient is without ASCVD and LDL less than 190, if the patient is without ASCVD and LDL less than 190, then what you will do? You will just go with moderate statin therapy. You will do moderate statin therapy. What is meant by moderate statin therapy? You will give rosuvastatin 5 to 10 mg and atorvastatin 10 to 20 mg. Okay. Now, if the patient is with atherosclerotic cardiovascular disease and LDL is greater than 190, low density lipoprotein levels is greater than 190, you will give high intensity statin therapy. You will give high intensity statin therapy. What is meant by that? You give rosuvastatin, how much? 10 to 20 mg, and atorvastatin atorvastatin, you give 40 to 80 mg. Okay. Okay, that is all about. If a patient came and you diagnosed it, he has high LDL levels with or without ASCVD, atherosclerotic cardiovascular disease, how will you approach? That's it. Now, what is the treatment of a patient with familial hypercholesterolemia? Hypercholesterolemia. Okay, what you do is simply start high dose statins. If there is no response, you simply go for add ezetimibe with it, or PCSK9 inhibitor. If still there is no response, you simply go with add lumitapide or abisumab. You add lumitapide or abisumab. Okay, so that is how you approach a patient with familial hypercholesterolemia. Okay, now how will you assess how will you treat the patient of hypertriglyceridemia? What you have to do is you first assess the risk of atherosclerotic cardiovascular disease. For example, if the risk of atherosclerotic cardiovascular disease is absent, you go for simply moderate. You check whether he has moderate triglyceride acid levels. Moderate means how much? 150 to 500 milligrams per deciliter. Or if he is having something like moderate to severe triglyceride acid levels, how much? 500 to 1000 or 999 milligrams per deciliter. If the patient has moderate TGA levels, something like 150 to 500, you simply ask him to follow some lifestyle modifications, to just draw some lifestyle modifications for the patient. You ask him to do these things. But if he is having moderate to severe triglyceride acid levels, something like 500 to 1000 milligrams per deciliter, you simply keep fibrates, clofibrates, gemifibrates, fenofibrates, any fibrate, right? Now, for example, if the risk of ASCVD, atherosclerotic cardiovascular disease, is present, if the risk is present, you simply start statins. So the condition is very much simple. The patient has a risk of atherosclerotic cardiovascular disease, you just start the statins, sure shot. That's the treatment. But if the patient has no risk of cardiovascular disease, atherosclerotic cardiovascular disease, you check the TGA levels. If it's moderate, it is something between 150 to 500, you just suggest him lifestyle modifications. But if he has TGA levels moderate to severe, that is 500 to 1000 milligrams per deciliter, just prescribe him fibrates, clofibrate, gemofibrate, gemfibrozil, fenofibrate, any fibrate, right? Now start statins. But if there is no response for statins, yes, chances are that your patient might not respond for statins. Add icosapent. If even that one has no response, TGA is still more than 500. Right? There is no response, go for simply add fibrates. Now this is the treatment for patient with hypertriglyceridemia. Okay. Now we go to the next chapter. What is that? Renal pharmacology. Renal pharmacology. Right. In renal pharmacology, first group of drug we are discussing about is carbonic anhydrase inhibitors. Right. Now, what does this carbonic anhydrase inhibitors do? They just block carbonic anhydrase enzyme type 2. This also you just remember, carbonic anhydrase enzyme type 2 in proximal convoluted tubule. So where are their uses? Where are they used? Acetazolamide, which is the famous carbonic anhydrase inhibitors, is the drug of choice in acute mountain sickness. Guys, remember this one. Acetazolamide is the drug of choice in acute mountain sickness. And acetazolamide or dichlorphenamide, they are used in familial hypokalemic periodic paralysis. Acetazolamide or dichlorphenamide, they are used in familial hypokalemic periodic paralysis. Now one more class of drug is loop diuretics. Loop diuretics, right? Remember this loop diuretics, how do they use? They simply block the sodium. I think I don't need to write all those things. These are basic things and you know it. They simply block the sodium potassium chloride pump present in the thick ascending loop of Henle. And they are the indirect vasodilators. They increase prostaglandins. Okay, they increase prostaglandins, right? They are the indirect vasodilators. Okay, so they increase the prostaglandins, but NSAIDs decrease these effects. They increase the prostaglandins, but NSAIDs decrease the effect. Now loop diuretics, where they are used? Loop diuretics, this is important, drug of choice in edema. Which edema? Can anyone tell? It can be renal or cardiac edema. Okay. Now furosemide, very important loop diuretic. Furosemide is the drug of choice in cardiogenic pulmonary edema. Now torsemide speciality is, it is the longest acting diuretic. It is the longest acting diuretic. Bumetanide, most potent. Bumetanide is the most potent. I will write this. Bumetanide is most potent. Ethacrinic acid, most ototoxic drug. Ethacrinic acid is most ototoxic drug. Most effective if GFR is less than 40, it goes for loop diuretics, because loop diuretics are the most effective drugs in case of low GFR, that is less than 40. Okay. Now coming to the next group of drugs, that is thiazides. Right. Coming to the thiazides, how do they work? Thiazides, they block the sodium chloride channel. And right here, thiazides. How do thiazides work? Thiazides mechanism of action is they block the sodium chloride channel. Sodium chloride pump. Co-transporter. Sodium chloride is a co-transporter. Where in DCD? Okay. These thiazides are direct vasodilators, but loop diuretics are indirect vasodilators. Thiazides are direct vasodilators. They open the potassium channels, so they are effective in hypertension. They simply open the potassium channels, that's why they are effective in hypertension. Now if you ask me what are their uses, they are the first line of drugs in mild, moderate hypertension. They are the first line of drugs in mild and moderate hypertension. They can also be used as add-on drug in edema treatment. and chlorthalidone is the longest acting. Chlorthalidone, longest acting. Chlorthalidone, longest acting. This chlorthalidone is preferred in hypertension management. This chlorthalidone is present in hypertension management. Chlorothiazide. Chlorothiazide. This is the shortest acting thiazides. Shortest acting thiazides. Next, indapamide. Indapamide, very important. Indapamide. This is predominantly, it excretes through hepatic pathway. This indapamide is the drug which predominantly excretes through hepatic pathway. All other drugs, they excrete through renal. Remember, all drugs, all thiazides excrete through renal, except which one? All other excrete through renal excretion except indapamide. Right? And one more drug in thiazides, it is metolazone. What is metolazone? Metolazone is a drug which is effective. It's a diuretic which is effective when the GFR is less than 40. Metolazone is the drug which is used or helpful when the glomerular filtration rate is 40. Okay. Now